Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Brazil, Professor Richardo Santos de Oliverira. Dr. Richardo is an associate professor of neurosurgery at the FMRP University of Sao Paulo and head of neurosurgery division at the Hospital das Clínicas de Ribeirão Preto, USP. He completed his medical residency at the Hospital das Clínicas de Ribeirão Preto, and he holds a doctorate and postdoctorate from the University of Sao Paulo. He furthered his training in pediatric neurosurgery at the Necker Hospital, Paris, France. He is a researcher and full advisor in the postgraduate program at the FMRP USP. He has published over 200 scientific articles and book chapters and has given numerous national and international lectures. We are extremely grateful to him for accepting our invitation to be a speaker at our webinars, and today we will be talking about principles of surgery for supratentorial and large brain tumors in children. The speaker for the second session of today is our very honorable guest from China, Professor Yang Hui. He is an investigator of the Huashan Hospital Institute of Translation Brain Research, Fudan University, who got the National Youth Talent Support Program, Shanghai Overseas High Level Talent, and Shanghai University's Distinguished Professor. He graduated from the Institute of Biomedical Research, Fudan University, with a PhD degree, and also joined the Department of Molecular Biology HHMI lab at the University of Texas Southwestern Medical Center to work on the regulation and function of innate immunity. He has published 12 important research papers in Nature and other journals as corresponding and first author. And we are extremely honored to have him today with us as a speaker at our webinars, and today we will be talking about targeting innate immunity in brain tumors to enhance immunotherapy. The chair for the first session of today's webinar is our honorable guest from the USA, Professor Frederick Book. Prof. Book was the T.J. Robertson Chair, Department of Neurosurgery at the University of Tennessee Health Science Center. He also served as the co-director at the Leibon Here Neuroscience Institute from 2004 to 2021, and he has held many international leadership positions, including President of the American Society of Pediatric Neurosurgeons, President of the American Association of Neurological Surgeons, and President of the ISPN. He is a noted author with several publications in various renowned journals, and is currently the member of the St. Jude Global Program and Emeritus Chair at the UTHSC. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable faculty from Germany, Professor Tarek Juratli. Prof. Juratli is the director of the Neuro-oncology Center at the National Center for Tumor Diseases, Dresden. He is the vice chairman of the Department of Neurosurgery in the University of Dresden, and he's completed his postdoctoral fellowship at the Massachusetts General Hospital in Boston, and his research focuses on investigating genomic alterations and molecular mechanisms in brain tumors. Surgically specializes in the surgical treatment of CNS and skull-based tumors. We are extremely grateful to him for accepting an invitation to chair the session of Professor Hui Yang. On behalf of the Education Committee of the ACNS and the President Prof. Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia and Dr. Ben from Hong Kong are my co-hosts for today. And with that introduction, I would like to hand over this podium to our first chair, Professor Frederick Book.
Well, thank you. Thank you to Professor Kato and Rajat for the nice introduction of everyone. I'll be brief because I want to give Richardo all the time we can for his lecture, but just keep in mind that when we think about causes of death in children worldwide, the number one cause is accidents and injuries, but the number two cause is childhood cancer. And of the 400,000 children who are diagnosed with cancer, and remember that many children may die without ever being diagnosed, the number one cause worldwide is leukemia, but the number two cause is a brain tumor. And now that leukemia is eminently treatable and in most instances curable, a pediatric brain tumor has become the number two cause of death in children. So it's important that we all understand the approaches to brain tumors in children. There are variant types. Some are malignant, some are benign, some are highly vascularized, which in a young infant or a newborn, or nowadays even with prenatal diagnosis of a brain tumor, trying to decide what to do if a child that hasn't even been born yet has a tumor that's causing hydrocephalus and so forth. There are a lot of issues that are relevant to a pediatric neurosurgeon in the management of these children. I can tell you at my stage of my career, some of the most rewarding Christmas cards, wedding invitations, graduation announcements I get are from children whose families I helped through brain tumors when they were infants and are now grown up, having children of their own and leading productive lives. So with no further ado, I'll turn the podium over to Richardo for his beautiful lecture.
Thank you, Professor Boop, for this kind invitation. It's a great pleasure to be invited by the Asian Society for Neurosurgery. Thank you, Dr. Raja, Dr. Ben, to introduce me. It's a great pleasure to share with you some our experience and to discuss about giant brain supratentorial tumors. So I will talk about the principles of surgery for supratentorial and large brain tumor in children. Our learning objectives in this lecture is to show you some basic introduction, planning, discuss some clinical cases, and of course, our results and comparison with the literature results, and conclusion the topic. So this giant supratentorial brain tumor is a very challenging tumor in pediatric patients because we have multiple factors that we can analyze it when we are in front of this tumor. One of the most important is the low blood volume in children and the high morbidity and mortality. The low success rate for selective embolization, as published in many papers. Signs and symptoms of raised intracranial pressure are very frequent in these patients. And the whole of the radio and chemotherapy because of the age, the diagnosis in very young patients. So what is the reality? When we look this MRI, you can see a very challenging tumor, a big tumor in a child 4 years old. So there are 3 critical questions that I would like to share with you at the beginning of this discussion. Is operative embolization feasible in this kind of tumor? What is the role of the neoadjuvant chemotherapy? And is biopsy rational for giant tumors? So we'll try to, in this presentation, to answer these 3 critical questions. So the first, I'd like to share with you our experience. So our primary goal was to evaluate the impact of the gross total resection in giant and supratentorial brain tumors and comparing the survival and the neurological outcome in a pediatric series. Nowadays, we have 28 cases, 15 cases under 3 years of age. So this is, as I told you, one challenge is the age. So it's most of patients with brain tumor, giant brain tumors, is under 4 years old. Giant supratentorial brain tumor can be defined as tumor larger than 5 centimeters. So it's really, you can consider really a big tumor. Our series is a long series from June 1998 to December 2025. And all the patients, we performed MRI or CT scans or both, obtained at the time of the initial surgical procedure. And look of this is the second problem is the hemodynamic support in our series. The average of blood transfusion was 51.2 milliliters per kilo. Look, this is what we defined a big tumor. So we can measure the tumor volume. So the diameter is larger than 5 centimeters in the CT, in the MRI or in the CT scan, can be defined as a large or as a big tumor. How we can plan the surgery. So it's very important regarding if most of patients are under 4 years old, we can do sometimes the ultrasound to research, to look for vessels, to look for the blood supply of the tumor. The CT scan can show us some calcification in the tumor. And of course, the gold standard exam is the MRI. And it's important on MRI to checking the vessels. So the veins, as you can see here, in this part of the deep part of the tumor, a big vein. So when you see a marked flow void in a brain tumor, in a giant brain tumor, usually means an excessive or could be an excessive bleeding during the surgery. So it's important to checking ultrasound, Doppler, MRI, and as well the CT scan to look for some calcification. So regarding our series, the patient mean age at surgery was 4.5 years of age, ranging from very early children, 27 days, to adolescents, 16 years old. The mean age of onset of signs and symptoms was really precocious, with 7 weeks. And clinical evidence of raised intracranial pressure was observed in the major of our patients, in 21 patients out of 28. And the mean volume of the tumor was over 200 centimeter volume, according to the MRI. Gross total resection or radical resection in 2 steps what was achieved in all patients. In 23 patients, 82%, only one single procedure was performed. And in our series, the extension of surgical resection was neither associated to increased complication rates or nor to poor neurological outcome or death. And patients less than 1 year of age received a great amount of blood transfusion than their older counterparts. And histological analysis reveal malignant brain tumors in the majority of patients in this age, in 75% of the patients. This is very interesting. When we look this kind of tumor, brain tumor in children, there is an heterogeneous types of tumors, as you can see here. So choroidal plexus carcinoma, rhabdoid tumors, PNET tumors, anaplastic ependymoma. So it's very different types of pathological analysis in this series. And when you look, the malignant tumors is the majority of our series, and 75% of patients present with high-grade histology. And it was correlated with the poor outcome. And in our series, 25% present choroidal plexus carcinoma. So it's most frequent specific pathological type in our series. So how can we plan? How can you do our surgical strategy and principles? First of all, after the initial planning with the neurological examination with the radiology, we planned a large craniotomy. Similar then, we do AVM surgery. It's essential for controlling brain edema and providing adequate exposure for safe manipulation. This is the most important step when we performed surgery in a big tumor is to have a large craniotomy to control every part of the tumor. The technology assistance, so it's important to be prepared and to have all the kinds of tools as neuronavigation, intraoperative ultrasound, US ultrasound Doppler, and ultrasound aspirator, and different forceps, different types of forceps to deal with this kind of tumor. The resection technique is usually subpial or transcortical en bloc, avoiding try to debulking or piecemeal resection, because to go is to minimize tissue trauma and bleeding. And the vascular control, it's important to early identification and control the tumor vascular supply to prevent massive blood loss. So the standard surgical sequence is to expose the tumor, doing a wide craniotomy and dural opening, devascularization of the tumor, coagulation of feeding vessels, unblock resection. Usually I do a circumferential dissection, controlling the vessels and coagulated mainly the veins, and finally the hemostasis of the cavity and checking. So this is the main steps of the surgical strategy. So looking for all the characteristics on the MRI, as you can see here. The vascular supply can be preoperative study using ultrasound, and intraoperative, the ultrasound Doppler it's very important because you can checking the deep veins, you can checking the vascular supply of the tumor. The large craniotomy that can provide you a good visualization of all the tumor, and you can attack the tumor in different parts to control and to try to remove the unblock, as you can see here on the final after resection. So now I will show you some clinical case. This is a big tumors. As you can see here, big vessels and the deep part of the tumor. This is very important when you can see this kind of tumor in infants. Is usually you don't have big arteries, but you have big deep veins because of the venous hypertension caused by the intracranial pressure, as due to the growth of the tumor. But usually there are no arteries or big arteries as a main vascular supply. There are a lot of different small arteries, as I will show you some angiography, and this is the main problem to try to embolization this kind of tumor preoperative, because you can see a good artery to try to embolization preoperative. So how can you plan the incision? You can do this kind of incision. It's very common when we do the compressive craniotomy. It's a T incision. This kind of incision, the advantage is provide you anterior, posterior, midline approach in a big tumor. The problem is this part of the incision, when this T part of the incision, but usually in infants the scalp is so vascularized and you can see big problems. So the most important is to you need to see all the parts of the tumor and to control and to remove the tumor en bloc, avoiding or minimize the bleeding. This is another case. It's a big tumor, some frontal parietal tumor, and you can see here after surgery, planning the large frontal, bifrontal craniotomy, control all the parts of the lesion, and at the end of the surgery, a total resection. This is a young child. It's 15 days old boy that the diagnosis was done intrauterus after ultrasound. So this boy was born, and we plan first. We plan a partial resection because the high risk try to remove this big tumor in this age. As you can see here, the first day CT scan showing just partial resection, doing some amount of tumors, and initially the diagnosis was probably a malign tumor, a diffuse midline glioma, and this child received 2 cycles of chemotherapy. However, after a histopathological analysis, a review of the histopathological analysis and the MRI control, we see the tumor is completely the same and growing during the treatment. And at this moment, the child was 5 months of age, and at this moment we planned radical surgery, and we did this. This was the first incision, and we add a second incision to have a good control of the tumor. And you can see here a complete removal of the tumor. And this is the postoperative, the later postoperative MRI showing no recidive or residual tumor. And the methylation profile reported showed us a benign tumor. It was probably a glioneural tumor. It's not completely defined, this diagnosis, but it's the pattern of this methylation profile is for a benign tumor. This is another case. It's our more recent case. I will planning the surgery for the next weeks. It's again, it's a 5 months of age old girl that presented with a full fontanelle, and this infant had a CT scan in another service and a VP shunt to control the ICP sinus. It's now the clinical condition of the child is stable. And what is our plan? It's doing right craniotomy, enjoy this cyst, this temporal cyst. So this temporal cyst is a large avenue to the tumor, but probably it's a big tumor involving the supracellular area in an infant, 5 months of age. And at the first, we're planning just a partial resection to have some amount of tumors, subtotal resection, and the diagnosis. So what we can talk about preoperative embolization. We try this technique. We have a good team for endovascular in our institution, but we try in 4 patients in our series. However, in 3 of them, they failed because, as I told you, there's just small branches of arteries that providing blood to the tumor. There is no enough size to enter and to control with the embolization, a good embolization. You can see here a tumor blush, but not good artery as a main supply of this tumor. So it's because it's very difficult to enter with a catheter and try to embolization the tumor. Of course, in choroid plexus carcinoma, the vascularization is more important, and in those patients, you can try the preoperative embolization. So, and about the follow-up and complications in our series, we had 80 patients showed significant intraoperative hemorrhage. Among them, 5 had choroid plexus carcinoma. So choroid plexus carcinoma is the most challenging, the nightmare tumor in this age. 11 patients developed some new deficits, and 3 of them had permanent hemiplegia after surgery. So the key prognostic factor in our series was related to the tumor histology. The tumor histology in our series was the only independent factor significantly correlated with recurrence and poor outcome. As you can see here in this Kaplan-Meier curve, it's a very different follow-up in these 2 groups of patients. So histology was the most important factor in our series. And about adjuvant treatment was performed in 17 patients, in 60% of patients. Hydrocephalus seizures was also present as in the postoperative in our series. And what is the most important when you use this technique in 1 or 2 or 3 step surgery is to control, raise ICP in the patients, because most of the patients, the majority of the patients came to us with severe intracranial pressure due to the tumor, or in some cases hydrocephalus, preoperative hydrocephalus. Death was present in 9 of our out 28 patients because tumor progression, non-operative mortality in our series. Of course, we have some problems. This is a very interesting case. It's a child, 4 years of age, presented a giant choroid plexus carcinoma, and we tried do an en-bloc resection, but during the surgery there was severe bleeding in different parts of the tumor, and we tried to make a damage control. So we stopped the surgery, we control the bleeding, and after we make the diagnosis, so confirmed a choroid plexus carcinoma, and in this case we performed a chemo and a second surgery. In a second surgery, we remove completely the tumor after the chemotherapy helped a lot in this case. Another problem in infants is this one, the persistent subdural collection. It caused when we communicated the subdural compartment with the ventricle. So how can you prevent this? Is after resection using fibrin glue to close the fistula between the ventricle and the subdural compartment. So in true big tumors, biopsy could be very difficult because the intracranial pressure and the brain edema. If you do a small craniotomy, thinking to remove a piece of the tumor to make a diagnosis, sometimes it's very complicated because you can accelerate it. Necrosis and apoplexy inside the tumor, and also it's very difficult because you can't control the intracranial pressure signs and symptoms. So it's complicated because the time that we see to make the diagnosis and how can you efficiently control this kind of intracranial pressure. So it's a limited surgery in this kind of tumor is very, very debatable. Excessive bleeding occurred in hypervascular giant brain supratentorial tumor. Even when you try do a piecemeal resection, because when you do a piecemeal resection, this kind of tumor is very complicated because the bleeding is so important, and you have a really, really problem in children because you need to have a great quantity of blood transfusion that will provoke different instability during the surgery, and you can't control in a time. So it's very complicated when you try to do a piecemeal resection, this kind of a tumor. So another problem is when we try to do just a biopsy, is the insufficient amount of tumoral tissue, because the heterogeneous, there are a lot of different kinds of tumors. So maybe a small piece of the tumor can make some wrong diagnosis. The delay in starting the adjuvant treatment and to see an efficient tumor reduction is when you do just a limited surgery. So this kind of tumor, the big tumors in infants, they may develop coagulopathy during the surgery caused by the loss of platelets and coagulation factor from massive blood loss. So piecemeal resection is so dangerous in this kind of resection. So as I told you, preoperative embolization can be performed in selective cases, such as choroid plexus tumors. And usually, the venous circulation is the main problem in those tumors. When you look the literature about brain supratentorial, giant supratentorial brain tumors, there aren't few papers published a series. So we selected these 4 papers published, and we analyzed these 3 factors: the staging resection, preoperative embolization, and neoadjuvant chemotherapy. So in this series, published in the most recent series, publishing in 2023, 27 cases, they did not plan a strategy, but they have more than 3 surgeries associated with worse follow-up in those series. Not used preoperative approach and methodology, preoperative embolization. And about neoadjuvant chemotherapy, chemo and radiotherapy used postoperative protocols, of course, depends of the diagnosis and depends of the age of the child. In our series, we recommended the stages resection in selected cases, following some adjuvant chemotherapy, as I showed you in case of, for instance, in choroid plexus carcinoma, when you have a severe bleeding. We attempted the embolization, preoperative embolization in 4, but failed in 3. So it's a high technical difficulty in infants. And the neoadjuvant chemotherapy is risky to do this with a big tumor. It's a hemorrhage and deterioration of clinical onset and may outweigh benefits. This is the large series published in 2017, but it's 60 patients. However, 43 patients in this series is tumors in posterior fossa and 2 in supracellular region. So we have 45 patients. There is no supratentorial brain tumors. So the stage resection in the Go et al. Series is part of comprehensive preoperative strategy. Preoperative embolization in that series strongly advised for hypervascular choroid plexus carcinoma when feasible, of course, and explicitly supports neoadjuvant for vascular tumor. They use neoadjuvant chemotherapy to reduce the size of the tumor. And this is another Brazilian series published in 2022 with 20 patients. They planned a staged resection to minimize blood loss and injury. They usually not the preoperative embolization in the Furtado et al. Series often not feasible due to patient size and small arteries, and not frame it as a standard preoperative debulking strategy, the new adjuvant chemotherapy. So, in our opinion, what are the main key takeaway points? So first, the biopsy challenges. Look, it's in true giant tumors, biopsy can be extremely difficult or contraindicated due to severe intracranial pressure and diffuse brain edema, potentially delay definitive treatment. Piecemeal resection. So standard piecemeal resection in hypervascular giant brain super tumors often leads to excessive bleeding. So given the limited blood volume in infants, this significantly increases shocks and mortality operative risk. So this is cause sometimes a massive blood loss and subsequently fluid replacement, rapidly depleted platelets and coagulation factors, leading to a vicious cycle of bleeding that is hard to reverse. The venous management. The venous circulation is often the main intraoperative challenge. Preserving major draining veins while managing high flow tumor shunts is critical for prevent venous infarction and to control bleeding. Selective strategies. Preoperative embolization, as I told you, is useful for selective hypervascular cases, but technically limited. Neoadjuvant chemotherapy may be considered to reduce vascularity in specific scenarios, and success relies on meticulous preoperative image and the integration of intraoperative tools like neuronavigation and ultrasound Doppler to identify vascular corridors. On conclusion, the management of giant supratentorial brain tumors in children demands a highly coordinated neuro-oncology team approach. Radical surgery is associated with remarkable improvement in clinical symptoms of raised intracranial pressure. The surgical strategy was not association in this series, and block excision was not association with increased complication rates nor poor neurological outcomes. And the only independent factor significantly associated with the decreased survival time was tumor histology in case of malignant grade, was the key prognostic factor in our series. So about some future directions, it's important to have more clinical series to standardize protocols for patient selection regarding preoperative embolization and stage resection to study these points, generate prospective mode-centered data to validate long-term functional outcomes, and refine the new adjuvant chemotherapy roles for hypervascular tumors in infants. I invite you to checking our journal. It's another option. It's an Archives of Pediatric Neurosurgery. It's an online English journal. So you can see here in this QR code what looks like the journal published by the Brazilian Pediatric Society. And this is my contacts. If someone has some question or to be in contact with us, I share with you our personal contacts. So thank you so much for this kind invitation, and I try to share our experience in this very challenging tumors. Is a nightmare for the pediatric neurosurgeon. It's not easy to treat, to deal with this kind of tumors.
Very nice, Richardo. That was a great overview, and it's an important topic. As we get into questions, let me start out with a couple for you. Number one, when we're talking about infants or young children with life-threatening tumors, I think one of the important discussions to have, and I would like your thoughts on this, is when not to operate. So, for example, if you have a biopsy of a deep midline tumor and it's ETMR, you know it's incurable, the child's going to die within a few months regardless of all treatment, do you move the child to palliative care or do you go ahead and operate? Likewise, if a child comes in and they're comatose and they're cachectic and they have a giant tumor, do you operate on a patient who presents in bad neurologic condition or do you advise against it? And related to that discussion, the staging, preoperative staging that you do with these infant tumors, if it looks like a germ cell tumor, do you check serum markers to see if upfront neoadjuvant chemotherapy may potentially be curative? Or do you always get a spine MRI? Do you always look at spinal fluid cytology, looking for metastatic disease? And if you see metastatic disease, does that influence your approach to these tumors?
Yeah. So thanks, Rick. So there are important questions. The first one is about the clinical condition of the infant. So, of course, if you have a very poor neurological condition, including a malnutrition or cachectic situation, you can really consider discuss with the oncology pediatric team and the family to decide the best alternative. Sometimes in this case, you can consider just a biopsy to have a diagnosis because look here in South America, here in Brazil, is very complicated not to have a diagnosis. Of course, we have some specific kinds of tumor, for instance, in the pons, infiltrative tumors. You can, in this case, you have the literature add you to not to do, for instance, a biopsy in a typical pons diffuse tumor. But otherwise, it's very complicated to consider not to do a diagnosis in child. It's very difficult. But in this specific situation that you mentioned, you need to define with the family and also with the team to have a best decision. Regarding the markers and the spine MRI, it's it's interesting because the series published by the group, the Indian group, in 2017, they add posterior fossa tumors. When we looked at there in that series, there are 23 patients with medulloblastoma. It's completely different because in medulloblastoma, it's part of the preoperative, the planning to have the spinal cord investigation. So when you separated just supratentorial brain tumors, excluding or not included posterior fossa tumor, pineal tumors, or supracellular tumors, because pineal tumors, supracellular tumors, you can see, for instance, germ cell, a big germ cell tumors, or a mixed teratoma, and the markers could be useful. In this particular situation, when you see only brain tumors regarding the cortical and subcortical region, usually we do not perform the spinal MRI routinely. Of course, it depends on the diagnosis. If you have, for instance, a very a malign tumor as a PNET tumor, maybe in this situation you can add a MRI, a spinal cord MRI investigation. But usually in our series, markers is only if you have a diagnosis showing some, for instance, an immature teratoma or something in this point, we avoided to include in our series posterior fossa big posterior fossa tumors, because it's another situation, it's another management of the tumor. So, but it's a very interesting question that you mentioned.
Raja, do we have any other questions from the audience?
Yes, I think Ben has raised his hand. Ben?
Yes, yes, and thank you, Ricardo, for your great lectures, and we indeed appreciate your experience in pediatric tumors. I have two questions. I want to ask. My first question is, what is the minimal age for you to consider that a child can be operated for brain tumor? Am I from neurosurgeon's view, or either from neurosurgeon's view, or from the anesthesiologist's view? My second question is about during the surgery, if you encounter bleeding, so when would you stop to consider a stage resection? Yes, that's my questions. Thank you.
Thank you, Ben. It's two very important questions. The age of the child. So, look, of course, now when we started to check in our series, it was in 1998, so many years ago. So you learn it. There is a curve of experience, and you learn a lot. When we became more experienced, we became more selective in terms of not avoiding to some problems. And the age, of course, is very important, because you have the bleeding, and then you can see a high risk mortality in this kind of patient, or for instance, less than 1 month of age. In our series, Ben, we have 2 patients less than 1 month of age, and we have this another case that I showed that I will do surgery probably in the next week, the next Wednesday. It's 5 months of age with a big tumor. But in this particular case, I think that now the best strategy is remove it partially, the lesion, to have the diagnosis. Because if you have, if you confirm it a malign tumor in, for instance, in five months of age or 1 month of age, so you can stop the surgery and doing the chemotherapy, and you can see another chance after 2 or 3 cycles of chemotherapy. It's more safe. Not try to be very aggressive in terms of surgery in this kind of patient, because the mortality is so high. Even if you talk with the anesthesiologist, if you have a good team of the anesthesiologist, but look, there is no miracle. If you have a if you have a severe bleeding in a child at 2 or 3 months of age, you can see a very high risk of mortality or morbidity in this kind of patient. So the second question is so important, is when you decided to stop the surgery because of the bleeding. This is very important. It's very difficult to answer, but it's very important question, because it's this kind of tumor, you need to start in the surgery and all the time checking and communicate with the anesthesiologist. If you see that there is more than 1-2 change of blood transfusion of the child, you will be in severe problem because of the coagulopathy, intraoperative coagulopathy. So there is a turning point that you need to check in. And before this point, you can stop the surgery to damage control. And look, it's better not try to go for, because if you try to go for in a patient that presents some instability in a child, is very complicated to control, even for experienced anesthesiologists. So it's mandatory to checking the MRI, doing ultrasound, intraoperative ultrasound, checking the vessels, and look, try to control. If you remove the part of the lesion, usually I start in a part of the tumor, and I started to remove it. I control the bleeding. I left in place some cottonoids or something, or gel foam, or some hemostatic agent to control the bleeding, and then I move it to other part, and then I move to another part. So look, different parts of the lesion, and you can control progressively the bleeding, not to try in this big tumor, not to try to go in a direction in the deep part of the lesion without a very good control in the circumference of the tumor. So, but if you have if you discuss with the anesthesiologist during the surgery and you decide, so there is the situation is not good, there is some instability, so it's time to stop it. So we stop the surgery, because stop the surgery, control the bleeding, and then you have a second chance after the diagnosis if you wait. But if you go for, sometimes the turning point, you can come back. So in child, it's very complicated. It's very, very complicated, because if you cross the line, sometimes you can't to control after this situation. But thank you for the question. I think it's not easy to answer, but the more you became experienced in children and surgery, listen the sound of the aspiration when it's so important. So pay attention, because sometimes you can a second chance.
See, thank you so much. Thank you, Ricardo, for your great presentation, great discussion, and also accepting our invitation to join the ACNS webinar. Thank you so much.
Thank you, Prof. Richardo, for this wonderful presentation. If I'd like to point out one thing, that these staged surgeries, I mean, for CPP are very common and are exceedingly reported, actually from Brazil, and as you rightly mentioned, that preoperative embolization is not always possible because of the very small choroidal arteries feeding it. And I found across this very interesting article about preoperative chemotherapeutic with vincristine, because it is a anti-VEGF properties. It may devascularize the tumor and may aid in resection. And also from another very classic report from Professor Richardo Ramina in Curitiba, Brazil, he mentioned that he had to stage 3 times a surgery, and during the surgery he had to inject onyx directly through a burr hole into the tumors. So like we know, it is very difficult tumors to treat. Nevertheless, congratulations on your wonderful series. Have you experience of using chemotherapeutic agents to devascularize the tumors in your center?
Yeah, thank you for the question. So I know very, very well Professor Richardo Ramina is a great surgery in South Brazil. And of course, maybe it's a particular case. So it's a very unusual case, and then he tried to do a intraoperative embolization. But it's not. Sometimes you can see more serious case more case to analyze if it's feasible or not. It's not easy because look, we have a good team for endovascular, a very very good team, and it's a guy that he has a huge experience in the endovascular, but for this kind of patients, less than 2 3 years of age, it's very very difficult to canalize it and to have a good embolization for this kind of tumor. Maybe in the choroid plexus, carcinoma choroid plexus tumor, you can see choroidal arteries that is a little bit more selective. And in this case, as I told you, preoperative embolization could be tried, could be attempted in this particular situation. Regarding chemotherapy, preoperative chemotherapy, yes. In some cases, I agree. Now, maybe after some years, there are more and more studies regarding. Now we are much more. We know much more in terms of biology of the tumors now than 10 years ago. So, new chemotherapy agent, as you mentioned, so could be useful for this kind of tumor. But remember that in big tumors, it's essential to have a diagnosis and then to apply chemotherapy. In our country, it's very difficult to convince the pediatric oncology to do or to perform the chemotherapies without a confirmed histology. So we need to have some histology, some kind of tumor, and then we discuss. I showed a case that was very interesting because we did a partial resection. The first histology showed probably malign tumors, but it was very difficult to analyze for the neuropathologist. But in that case, we decide for the preoperative chemotherapy. So the team, the oncology team, they performed the 2 cycles, but we didn't have any answer, any reduction, efficient reduction of the lesion. But in this case, we decided for the second surgery. And during the second surgery the surgery was very nice because we removed completely the lesion. So probably in this case, the chemo help us in terms of reducing the vascularization and help us to remove the lesion. Yeah, but look, there are few information about this on literature. So there are some selective cases published, but yes, I know. I agree with you. Could be an alternative to have some preoperative chemotherapy in selective case.
Thank you very much. Any questions from Liu Bun Seng, my co-host?
Thanks, Raja. Thanks, Prof, for a very comprehensive discussion and talk. I have 2 questions, Professor. In adult, we do experience, for example, in olfactory groove meningioma, which are very bloody. Sometimes when we go second stage, we tend to induce thrombosis during the first surgery. And when we go in second time, in 1 or 2 weeks' time, it get less bloody. Do you have the same experience with large pediatric supratentorial tumor? And if so, which type? And if the histology are important in this, do you think that frozen section will be part of your management? My second question, Professor, regarding the reliability of intraoperative monitoring for pediatric cases, for example, motor monitoring. How reliable are they comparing to adult, and how often you are using them? Thank you.
Yeah. So for monitoring children, it's not easy. We have a good program in our institution regarding epilepsy surgery for adults and also children. We have a good experience in intraoperative monitoring during epilepsy surgery. But in children, it's not easy to monitor in the motor area. So we didn't use usually in this kind of tumor intraoperative monitoring because sometimes it's not efficient to selective the motor area. From the meningioma, the meningioma in adults, we have a experience. It's interesting because sometimes you can do a preoperative embolization that helps you a lot. So if you look skull-based tumor, for instance, internal wing sphenoid meningioma, big sphenoid meningioma, sometimes you can embolization preoperative, and it's okay, it's good. You can see on flow void sinus on MRI preoperative, and the side of this doing angiography, a preoperative angiography, and to discuss with the team and try to embolization and do the surgery safer than not embolization. In terms of child, it's sorry. It's complicated. I don't know what is your experience in terms of embolization. Do you have experience in embolization for children?
No, I'm not meaning the real embolization. Mean the first surgery will be some form of precursor for induced thrombosis. So when we go in second time, we tend to have less bleeding. So whether you have the same experience with the pediatric tumor and which type of tumor, if so, that those cases are safe for stage surgery rather than one single surgery.
No, in this case, no. I did have experience with this kind of thrombosis, preoperative thrombosis. I don't have experience.
Yeah. No, what I mean is because of your first surgery, you will be surgically induce the thrombosis. So when you go in second time, it will be less bleeding. Do you have such experience with pediatric tumor, Professor?
Yeah. Using a kind of thrombosis before during the surgery.
No, not really. It means your surgical procedure itself. Because we do experience this in adult. Sometimes by using a bipolar over the tumor surface, which are very bloody, we tend to go for stage. When second time we came in, usually they are less bleeding. They already induced thrombosis by the surgical procedure itself. Whether such experience with the pediatric tumor, Professor?
You talk about, for instance, to have the first surgery, try to remove partially the lesion, and then a second surgery could be better because you have some thrombosis and less vascularization of the surgery. Okay.
Yes, that's what I mean.
Yeah. You can see sometimes it's you can see, for instance, choroid plexus tumor. You can plan for more than one surgery, maybe one surgery. You do the first surgery, you confirm the diagnosis, and then a second surgery could be better because, as you mentioned, yes, you can have some thrombosis, some venous thrombosis, and progressively you have less bleeding in a second surgery. It's it's because now, as you mentioned, you have more experience and you check this information, and maybe it's better to stop it and try a second look surgery than try to do in just one surgery. Of course, sometimes it's okay. You can control during the surgery and can remove unblock the lesion. But sometimes if the blood loss is significantly, and it's better to make, as you mentioned, try to control and then to reanalyze the patient and then make a second surgery. Yes, I agree. I totally agree with you.
Thank you very much, Professor.
Thank you very much. We would love to hear Professor Rick Boop's experience and his philosophy of staging extensive bleeding tumors.
Well, thank you. It's a difficult situation. First of all, we want to make sure that our anesthesiologist has blood in the room before we start the surgery, and we want to calculate the child's estimated blood volume so we know. Typically, if we have replaced 2 blood volumes, we'll try to stop and stage it, because we know that if we get much beyond that, we risk a coagulopathy. Second of all, in young children, if the blood has had a long shelf life and a lot of the cells have hemolyzed, then there may be high potassium levels. So we like to use washed red blood cells in young infants, so that if we have to give a lot of blood, they don't get hyperkalemic. We've seen children arrest from hyperkalemia from blood transfusions. And then the third thing is in very young infants, trying to use irradiated red blood cells so we don't risk giving them a transmitted virus from the blood cells, because then if they need chemotherapy and they have a viral infection, we are in a conundrum. So that's mainly for us. As a segue to the next lecture, I'd like to just make the comment that we're starting to see in the United States situations where a surgeon tries to operate on a tumor, for example, an optic pathway low-grade glioma. If the patient wakes up with deficit, then the family is suing the surgeon saying, well, if you had just given a MEK inhibitor, this child would have normal vision and the tumor would have responded and you wouldn't have had to do this radical resection. So it's an interesting time for neurosurgeons right now, because for tumors that do have targetable mutations, sometimes biopsy and a MEK inhibitor, for example, may be an alternative to a radical resection in a young infant.
Thank you for your very wise comments. I think you can conclude this session, Prof. Boop.
Yes, it was a beautiful discussion, and it's one of those that could go on all morning. You can write a whole book on this topic, but I'm very excited about the second lectures, and because this may be the future for these young children with difficult tumors.
Right. Thank you. Thank you very much, Prof. Richardo Santos and Professor Frederick Book, for taking out your valuable time in support for the ACNS webinars. I would like to mention that this has been broadcasted on WeChat, YouTube and Zoom, and as of now we have 450 people who are live on all the 3 channels combined. So thank you very much, especially to Professor Shubin for broadcasting this on the WeChat channel. We'll move on to the second session. Professor Hui Yang from Fudan is ready, as well as Professor Tariq Juratli, who is the chair. I'll hand this podium to Professor Juratli. Please.
Yeah, thank you very much, Raja. Thank you very much for the invitation. And we're going to switch gear. And as Dr. Boop already marked, it's a very important topic, neuro-oncology. And Dr. Yang is going to talk about targeting immunity in brain tumors to enhance immunotherapy. So as you know, while immunotherapy has transformed the treatment of many cancers, think about melanomas, for example, its impact on primary brain tumors, specifically malignant brain tumors like gliomas, has so far been limited. And one major reason for this is that the unique tumor microenvironment of the brain, which is characterized by a lot of immunosuppression and relatively low infiltration of adaptive immune cells such as T lymphocytes. So that's why CAR T cell treatment, for example, failed in treating patients with gliomas, for example. So instead, brain tumors are heavily populated by innate immunocells. When we talk about these innate immunocells, what do we mean? Then we mean specifically the tumor-associated macrophages and microglia, which can represent a large proportion of the tumor mass. That when we resect the tumor, you think like everything is tumor cell in it, but by the way, you're gonna have a big portion of that tumor just infiltrated by microglia and macrophages. So these cells often adopt an immunosuppressive phenotype that promotes tumor growth and limits the effectiveness of current immunotherapies. However, over the past few years, our understanding of the role of the innate immunity in shaping anti-tumor responses has expanded significantly the way we think. So innate immune cells are now recognized as central regulators of the tumor microenvironment and potential therapeutic targets. The strategies that people are using now are aimed at reprogramming the macrophages that are tumor-associated, targeting myeloid immune checkpoints, and activating innate immune signaling pathways. How do we do that? And I think I'm going to handle to our next speaker, to Dr. Young, Professor Young, who will provide valuable insights into this rapidly evolving field and discuss how targeted innate immunity may open new avenues for more effective immunotherapy in neuro-oncology. Please, Dr. Young.
Okay, thank you. Thank you for your introduction. Yeah. Let's start. Yeah. Today I will share some source about the targeting innate immune signaling in brain tumor immunotherapy. So as I mentioned, I think it's half a year I give a talk, and I also give a talk on this November is talking about some metabolic signaling and regulate the innate immunity. So today I will try to give a summary or some real insight from this side to brain tumor immunotherapy. Okay, to begin with my talk, in the first time I want to introduce the innate immune system in the cells. As we know right now, in the innate immune system is the first line of the defense against the pathogens. It was recognized. The pathogen was recognized by the pattern recognition receptors such as toll-like receptors, and also RIGA MD5 and CGAS, which can recognize double-stranded DNA. And these receptors can detect these pathogens with pathogen-associated molecule like LPS or single-strand RNA or double-strand RNA. So after recognize this molecule, the protein, the receptor will activate the downstream signaling like TRIP-MDA8 or MAFS skin, and then activate the transcription factors like IF3 or NF-κB to trigger the production of type 1 interferons or other cytokines to boost the anti-pathogen immunities. So in my talk today, I will talk about how this system works in cancer immunotherapy, especially for the interferon signaling pathway, and then I will talk about some stories, short stories about how could we use these systems to improve the immunotherapy for brain tumors. As we know, the concept of activating the innate immunity to treat cancers actually dates back to more than maybe a century. And the first time is in the 1943. Sherry and Turner demonstrated that the anti-tumor immunities of a pathogen called cholecystokinin was made due to the molecule called LPS, and later Bruce Butterfield and from right now he's in the UT Southwest, and Julia Hoffman discovered the receptor of LPS in the cells. It's called toll-like receptor 4, and they because of this discovery, they won the 2011 the Nobel Prize of this So over the past decades, many innate immune pathways has been identified beyond the toll receptors, including the RIG-I, MD5, similarly, and also the most recently discovery of the SIG-STIM pathways. This discovery has significantly advanced our understanding how the innate immunities contribute to tumor immunities and open new opportunities for the therapeutic developments. So the innate immunity in the anti-tumor immunity response, it has like two steps to works. As we know, the immune checkpoint therapies always shows only maybe 20 to 30% of response overall because of the cold environment, like cold environment with less immunity for the T cell infiltrations. So when we use this, we use this innate immune system, and if we activate this innate immune system by the ligand or even like tumor derived damage patterns, it will activate the antigen cross-presenting cells and also enhance the T cell primings. So for the SIG-STIM pathway, like in the right, the pathway always like activates by the ligand called CGAM or some other molecules or even DNA from tumor cells, where trigger the activation of this pathway either in disease and the cellular cells or like NK cells. All these cells will produce type 1 interferons. This molecule will then recruit DC cells and then CD8 T cells and activate TC cells to kill the tumors. So this is the first step. If we activate the innate immune system, it will recruit and activate the T cells or DCs to boost the anti-tumor immunity. But however, as mentioned by before, the immune cells in the tumor microenvironment, even in the glioma microenvironment, often is an inhibitory state. It will cause the immunosuppressive microenvironment. So when we use the innate immune pathways, if we activate the pathways of SIG-STIM, then we can activate the microenvironment by produce the type 1 interferons or even cytokines called CXCL10 or other cytokines. The CXCL10 always can recruit more T cells infiltrated to the microenvironment, and the type 1 interferons can activate the T cells, then make the more efficient to kill the tumors. So this is a reprogramming systems, yeah. And very recently, and I think a lot of companies and also labs want to develop lower STIM and agonist, just because this molecule can direct activate STIM to induce type 1 interferons to improve anti-tumor immunities. So 5 years ago, 2 science papers back to back to develop to new STIM and agonist. These 2 STIM activators is just a long. It's not the same as the CGAMP, which is the endorsed one. It's long nucleotide based STIM activator, and also the other one, it can also be oral delivered. So it's more convenient for the patients to use these drugs. So this is some background about the innate immunity, especially for the SIG-STIM pathway in the cancer immunotherapies. So the next step will move to the how to use these 2 pathways to treat brain tumors or some with some updates. Actually, the lab a lab in Fudan University, and we also still work on these 2 paths. So today I will give you some insight. As you know, the DNA pathway, the SIG-STIM pathway, also called a DNA pathway, it starts maybe 100 years ago. The first is 1908 and people found the DNA can stimulate immune response. And later in 2008, maybe it's a 4-level independent discovery the molecule can involve in the DNA immune synthesis. And for the Glenn Barber's lab, it's called STIN, and some other lab like Hongbin Su's lab in Wuhan University called META. And the other 2 labs laid this protein as ERAS or MIPS. But finally, most delay of this protein, most used one is the STIN right now. In 2008, and the lab from James Chen in UT Southwestern, which is my postdoc supervisor, the lab discovered the most important and the last proteins which can direct bind to STIN and generate secondary immune molecules called cGAMP. So this discovery and fully understood how DNA can trigger the immune response. So what's the DNA pathway? And usually it's simply it causes a sensor protein called cGAS, which can bind to DNA and catalyze the ATP and the GTP to synthesize cGAMP. And then cGAMP binds to the ER loading STIN, and then STIN activates the trafficking to the Golgi to boost to activate the downstream molecule called TBK1 and F3 and activate the type I interface. In the double-strand DNA, if you for the pathogens, the double-strand DNA always from the DNA virus or some bacteria, and some richer virus for the single-strand RNA, it can be reversed to double-strand DNA, also can activate the cGAS STIN pathway. In our cells, there's resistance to protect our cells from activation of the cGAS. If we have like a small amount of double-strand DNA in the cells, like when we cause some, when the cells has some stress, cause some DNA damages, and the enzyme called TREX1 in the cytosol, and another enzyme called DNase2 in the lysosome, and the third enzyme in the nucleus called RNase H2. Among all the 3 enzymes can digest the double-strand DNA to avoid the auto-activation of cGAS. And actually, mutation in these 3 enzymes will cause autoimmune disease, such like lupus, and some other like autoimmune disease. And the other thing is when tumor cells cause with some drugs like chemical drugs cause cell death, and the cells will also release the damaged DNA to the cytosol, and also will cause the activation of these pathways. And recently, this pathway was mostly studied and connected to a lot of like diseases such as neurodegeneration diseases and cancers, and some metabolic disease like diabetes, and what I have mentioned is autoimmune disease, which have some like genetic connections. So this is a summary of these pathways, and as the first is the immunologists want to try to get understand how the virus activates the immune systems, cause antiviral immunities. So it's like the 2 protein called cGAS and STIN activate the F3 transcription factors. So when I joined the lab from in the James Chen's lab, and I'm basically my majorly works on the endogenous, how DNA damage can cause the cellular DNA trigger the innate immune response. What's the function of this? So to summary, and my work discovered 2 new functions of these pathways. The first one is the pathway is essential for the cellular senescence, and it will cause some like tumor inflammation. And also we have discovered this pathway has very prior functions will cause the autophagy. This autophagy will also cause the tumor invasions. For the details of these pathways, as I mentioned in the first part, it is the production of type 1 interferons will cause the activation of T cells and the disease, which we are priming the tumor killing effects. And mostly important, as we know, the T cell is a therapeutic immune cells. However, in our experiment, when we deplete or sting in the mice, but not other toll-like receptors like toll-like receptor 4 or toll-like receptor 8, the mice fail to reject the growth of tumor cells with the spontaneous B16 models or even irradiation therapy models. So this means the traditional therapy like irradiation or chemotherapies will also rely on the innate immune system, especially for the DNA pathways. So other important roles for these pathways is immune checkpoint therapies. As we showed here, if we lock out a sting or C-gas in the mice and then combine the PD-L1 therapy, in the wild type mice, we can see a significant inhibitory effect of the tumor growth and prolong the tumor survival, the mouse survivals. However, when we lock out sting with sting golden ticket mice or even the C-gas whole body lockout mice, and the anti-tumor effect of the PD-L1 will reverse, just like as I say with the wild type 1. So this in vivo data, showed that both the innate immune signaling molecule like C-gas or sting is important for the anti-tumor immunities. And as I mentioned before, this two drug immune checkpoint therapies is very successful in some cancer types like lung cancer or other cancers. However, the overall effective rate in the pan cancers is about 20 to 30%. If we zoom in to see the brain tumors like the GBM, as mentioned here, and it's really long response, it's really low response here. So several clinical trials targeted PD-1, PD-L1 in glioma was failed. So this is a very a disappointing point here for these two successful drugs. So if we further to analyze this data with the expression of the innate immune molecule called C-gas, we can see here the higher expression of C-gas will correlate a little bit of responders here. So that means the innate immune system is important for the immune checkpoint immunotherapy in brain tumors. When we use the mouse models, if we treat the mouse with PD-L1 either in the wild type mice or the C-gas knockout mice, as we showed here, in the wild type mice, the tumor is under control. However, in the C-gas knockout mice, even when we treat the mice with the PD-1, the tumor is even larger than the wild type mice myself. So that means the C-gas is important. The DNA synthesis pathway of the innate immune system is also important for the immunocheckpoint therapy. So even though this immunocheckpoint therapy is required the T cells, which is adaptive immune resistance. We want to try whether there's some other ways through the upregulate the innate immune system can trigger much powerful anti-tumor immunities. So my previous works have showed the chronicle, which can inhibit the autophagy where accumulate the stem proteins, and then will cause, even when we use the same amount of C-gas, will cause a higher expression, higher phosphorylation state of TBK and ALK3, and this will cause an increased expression of type 1 interferons. So from this evidence, so we use in vivo models and we inject the mice with small amount, low dose amount of cGAMP will cause a slightly inhibition of the tumor growth with this immune secondary messages. And also we use a moderate dose of the CQ, and we are slightly decrease this tumor growth. However, if we combine these two, which will cause a more activation of type 1 interference, the tumor growth is totally under control. So that means if we use some conditions like to boost the more efficient the activation of STING will cause some enhanced anti-tumor immunotherapies. To summarize this part, I think and a lot of papers has focus on the regulation of the cGAS-STING pathway to improve the anti-tumor immunities. However, this pathway is also has the dual roles for the anti-tumor immunity. If we acute activate these pathways, it will promote the anti-tumor immunity with the production of type 1 interference. So mostly sometimes the activation of this pathway becomes chronic. It's just because of ligand like DNA or some other ligand, the amount of this ligand is very low. So the system is a chronic effect where cause activation or other transcription factors called NF-κB. This will use the gene expression, which also called senescence-associated secreted phenotype. It contains more than 90 inflammatory cytokines or chemokines. So this effect will cause a suppressive effect will promote tumor growth. So if we want to use these pathways, we can use acute activation ways to activate these pathways and just boost the very high level of type 1 interference production and boost anti-tumor immunity. By using this way, they may have some problems that will cause overexpression or stimulation of the production of cytokine molecule will cause a cytokine storm, which is very dangerous to the people. So the better way to boost this pathway or use this pathway to treat tumors, we think is just we can reprogram the chronic effect from the chronic activation to the acute activation within the tumor microenvironment. So that's very important. We need to try to find a tumor-specific regulation of these pathways. Back to the expression or some evidence about glioma, about the cGAS-STING pathways, and it's 3 years before Cancer published a small letter of papers. This paper just found the STING expression is just the expression of STING is silenced just by the DNA hypomethylation state. So if we use the DNA methyltransferase inhibitors, which can restore the expression of STING and then reactivate the immune responses. So another alteration is IDH mutations. I think most of the people works on these pathways, work on gliomas, is very familiar with these mutations. With these mutations in the cells, it will cause accumulation of a metabolite called 2-HG. And from my previous works, we just showed this accumulation of 2-HG can competitive with another metabolite called FKG, which is important for the TET and KDM activities. So with high amount of 2-HG, it will inhibit the DNA demethylase TET activities, will cause the DNA hypomethylations and then alter the differentiation of the cancer stem cell and then cause the tumorigenesis. This is the mechanism which was reported when I was a graduate student in Fudan University. So with these inhibitors, and it just recently reported, and it can also reactivate the pathways by just like by cause the expression of cGAS will just because in the mutant samples it will show the cGAS expression was decreased. So when we use this IDH IDH mutation inhibitors, it will just upregulate this signaling pathways, cause a very moderate expression of both the cGAS and STING expressions. With this upregulation of these two molecules, key molecules, it will cause the activation for UP3 and then cause the induce of effect called virus effect it's just a lot of genes as type 1 interferon or type 1 interferon induced genes. So for this for these papers, it's just show the dual therapeutic mechanism of mutant IDH inhibitors, and the first thing is called viral mimic immune signaling and restore the interferon related responses. So the second things mentioned by this paper, maybe we can combine with innate immune agonist to enhance mutant targeted glioma immunotherapies. Another side of this to use these pathways is cause the viral mimic response to enhance these immunotherapies caused by the DNA damage drugs or radiation, as mentioned before. And back to the cellular assays, if we irradiate these cells or use chemical drug to treat the cells, it will always cause some DNA damages if we use the DAPI to stain the nuclei of these cells. Within some cell, we can see there's a signaling in the cytosolic these stores. Usually they called micronucleus. In our previous studies, we showed the micronucleus. In the micronucleus, it will also accumulate a lot of cGAS proteins in these stores, and it will also cause some other changes and maybe some ritual element signaling in the outside of the nucleus in the cytosol. So all of these elements, either micronucleus and also ritual elements like the ERV, these elements will recognized by either by cGAS or MDA5, where then the signaling will then activate the IF3 or IF7, cause the interferon responses. So this endogenous DNA damage signaling caused by the traditional therapies will also activate the immune systems. So if we use this system, we can boost very strong, as you show the white type mouse. If we use the irradiation, will cause very strong tumor inhibitions. However, if we lock out the STING molecule, it will also the STING molecule also called TMEM 173. If we lock out these cells, as shown here, the irradiating effect of the tumor growth was largely abolished. So that means the traditional therapies like irradiation or maybe I didn't show the data today, like some chemotherapy such as TMZ will also cause the activation of the immune response, which is depends on the STING signalings. So other treat methods which was I think mentioned by many people is called the tumor treating fields. So for this device, as shown a paper as shown here, if we treat the cells, it will also cause the accumulation of the micronucleus and even some bridged DNAs, which accumulates the double-strand damaged DNA in the cytosols. So when we use cGAS proteins to or M2 other like DNA sensors to staining with these ones, we can see the very significant colocalization of these proteins with damaged DNA. And after that, if we analyze the sequence data from these samples treated with TDFS, it shows the treatment can activate the STING or AMP2 related immune response to induce the anti-tumor immunities. So that means the newly developed treatment also can activate the innate immune systems, which generate type 1 interference and also some cytokines to activate the tumor microenvironment. More importantly, there's another like clinical trial called EF14. It is like combined TDFS with TMZ treatment, when the data shows significant improvement of PMFS or OS in the GBM patients. So another experiment is use the TDFS to combine with PD-1 block therapy with also improved the PFS in the newly diagnosed GBM patients. So for the mechanism part, and as I showed the JCI paper just mentioned, the TDFS will work on the damaged, will generate some damaged DNA and then binds with either with AMP2 or CGS to generate the activate cytokines will recruit more T cell, NK cell, and the DC cells, and activate these cells to activate microenvironment to improve the PD-1 therapies here. So, so if we like think more on this part, as I mentioned before, so this is like a complicated system. So it has shows dual roles in the activated tumor microenvironment, and so from the data that I showed a few slides before today. So if we use selective targeting these pathways or this innate immune networks, it will like more precisely to treat the tumors just in the side for the anti-tumor immunities. So I think there's several directions we need to like work on. The first one is like we need to characterize the innate immune signaling dynamic in the GBM microenvironment. The second one I think is also important to define the cell type specific innate immune signaling during the tumor progressions or even tumor developments. So the third one I think is like therapy, how the therapeutic ways. I think we need to design to rational combinations, even use the tumor specific the therapy combined with immune checkpoint. We are targeting the innate immunities. We are specifically activate the microenvironment part in the tumor site. So the third one I think is most important right now. I think that's as a single cell sequence or spatial single cell sequence like KIMS, and there's more omics data. So we need to integrate this multi-omics data and use AI to analyze this data to generate a more precision immunotherapy ways. So I think this is all what I want to share today. I want to thank Imao from Huashan Hospitals and all the other people. Thanks.
Great. Very impressive talk. Thank you very much. Was really impressive. Congrats on your great work on advancing this field, which is very important. So I'm going to start with two quick questions. So it's very interesting showing that you looked not only at the innate immunity, but you also looked at the molecular signature of tumors. So you classify tumors based on IDH mutations, IDH wild type, and so on. That's very interesting. So do you think, so with your last slide showing the future, your future work. So when you think about the 4 steps, the 4 things you mentioned, so what do you think, what is the most important cornerstone in IDH mutant gliomas?
Yeah, very good questions. I think, yeah, the important thing I think in IDH mutant ones is like I think the immune cells, when we like sequence the tumor samples from both IDH wild type and IDH mutant side, usually in the IDH wild type tumors we see more T cells in these samples. However, in the mutant ones, the T cell is not the amount, the percentage of T cells is not as high as white one. So I think the best, the most important thing is use these pathways to generate the recruitment effect. Just recruit more T cells in this sample, in this kind of tumors is important. So more recently, I think the inhibitor, like the drugs on target the IDH mutants, right now is a clinical trial in China, and most of the mechanism what we learn now is depends on the cell death. Yeah, the drug will cause the cell death of mutant IDH mutant cell cancers. So if the drugs cause the death of this mutant cells, and it will also release some damaging associated patterns such as double-stranded DNA. This DNA also will goes into the cells beside of these death cells will also cause the innate immune activations. So I think for this mutant ones is it will more important to use the in mutant drugs and combined with some combined with some innate immune activators. And I think this combination will precisely improve the tumor microenvironment to cause the more effective anti-tumor immunities in the IDH mutant patients.
So did you have the opportunity to get samples of patients treated with vorasidenib with an IDH inhibitor, for example, to look at the microenvironment of these samples, like if they look different than normal IDH mutant naive tumors? Any differences in the microenvironment where you see difference?
Yeah. This is the samples. I think this kind of sample is most important to see what will happen. Yeah, but right now I think in China is just a clinical trial right now. We don't have chance to get the samples. I think the sample is still there. Yeah, maybe after the trial was finished, we can get some from the hospital. And the trial is right now is in Tiantang Hospital and Huashan Hospital in China right now. Yeah.
And in terms of TTF, I didn't know that TTF has any impact on the innate immune system, to be very honest. So, but when you see, you show that GCI paper, I wasn't aware about that paper, to be honest. But so did you look at the GBMs, like IDH wild type GBMs, basically before and after treatment, and looked at the microenvironment based on TTF? So that was let's say the result is showing that there is a shift in the microenvironment because of TTF?
Excuse me, you mean what kind of cells, what kind of tumors is effective?
Yeah, the microenvironment. If the innate immune system is different in TTF treated and TTF naive glioblastomas.
Oh yes, and I think that this is depends on the other things I think I mentioned here is also very important in gliomas. It's just because the pathways in some of the tumors, the P molecule called STING is just silenced by the epigenetic ways is hypomethylated. And also, some of the CKS protein is also silenced in these samples. So, but when we check the glioma samples, we see some glioma stem cells has the whole pathways with a moderate expression of both CKS and STING in the cells. So I think for the TTFields treatment, and the induced immune response is cause of this DNA damage. So if the cells has a moderate expression of CKS or STING, it will works. It will just activate the microenvironment. But if the environment, if the tumor cell don't have these pathways, and I don't think this system will works well. Maybe just cause the damage of tumor cells. However, as you mentioned, I think in the introduction, there's some innate immune cells in brain tumors, like monocyte called microglia. So some of the microglia maybe can eat some damaged molecules from the tumor cells and treated by TTFields will also activate resistance. So I think there's a tumor intrigue or tumor non-intrigue effect from these activations. Maybe we need to use the genetic models to show how important of these pathways in the microglia or in the tumor cells and later, yeah.
Okay, very interesting. Thank you.
Yeah, thank you.
I see Dr. Ben has a question, right?
Yes, Ben.
Yes, and I'm also interested. First of all, thank you, Professor Ying, for your great lectures, and very interesting. And I'm also interested in about the TTF with the innate immunity. So when we talk about TTF, we talk about the duration of the patient wearing the TTF. So in your study, so what is the minimum duration of the TTF the patients have to receive in order to benefit from this innate immunity pathway?
Oh, that's a really good question. So yeah, actually we didn't know, just because for the TTFields device, yeah, just we want to do some mouse studies. It's hard to use this device to do the mouse studies. We cannot do to fully illustrate the microenvironment change during this treatment. We did see some patient samples. We can see some signaling pathway was activated. Just I mentioned in my last questions, some immune cells did really show some activations like production cytokines called CXCL10 or other molecules will also recruit more T cells. This is what we have right now, and so I think the most important is we can make a device we can use in the mice, so we can to treat the mice according to the patients and have the samples to analyze how the microenvironment change. Maybe we give the true answers how to improve of this one, or what kind of patients are more sensitive to this treatment to improve the immune resistance. Yeah.
Thank you so much.
So I have any other questions? Otherwise, I would have
none so far. Please go ahead.
Yeah. So yeah, one question is, so when we talk about so are you aware of medications that inhibit STING in so severe way that you would say this is a bad treatment for patients with, let's say, IDH wild-type glioblastomas? Any kind of treatments, so not only chemotherapy, maybe something else, maybe something for, I don't know, for antidepressive treatment or whatever.
So you mean, is there any other combinations is better for the IDH wild-type patients treatment? Is it right?
Yeah, or is any inhibitors of STING, like if severely, let's say severe inhibition of STING caused by some medications, where you say, oh, this is bad or this is good for tumor treatment.
Sure. I got it. Yeah. Actually, like in brain tumor, especially in brain tumors, the only drug in patient right now is TMZ. So for this drug, it will also like cause the activation of type 1 interference in different kind of cells. And I think the paper reported we also repeated this data. But you mean is there any other like inhibitor effect? Right now, there's only one paper reported is the silence of this pathway just like use the hypomethylations. So when we use another drug called is from the DNA methyltransferase inhibitors, will cause the inhibition of DNA hypomethylations of STING, and this drug will restore the expression of STING molecules. And at this side, you can use the activators of STING to boost the immune response. So I think if we see some like patients without expression or of the pathway was inhibitor like STING, so maybe we can use the epigenetic drugs to restore the total activities, and then we still have chance to activate these systems.
Interesting. So, and the combination radiation and then chemotherapy, or first chemotherapy or then radiation, do you think that would also impact that innate immune system as well somewhere about the STING pathway? So like if you do first radiation and then you do, let's say we will talk about IDH mutants. So first you do radiation, then you do chemotherapy, or vice versa. What do you think? What is better in terms of the STING pathway?
That's a really fantastic question. Just because this is I think I've talked about some doctors in a hospital. They are just doing like a chemotherapy or irradiation therapy, and right now most the ways they treat the patients is just normally to kill the tumor cells, just like simply just use high dose or a dose, moderate dose just kill tumor cells, which will not cause some severe side effect. And from the some clinical trials or even in the mouse studies, if we use the low dose irradiation treatment or low dose chemo drugs and with like daily treatments, and this like this way, so you will not cause very severe side effect, but it will cause the activation of the immune systems in these patients. So, but this activation, the amount of this the activation is moderate, is not as high as enough as the acute ones, acute activations. So it will not cause very severe anti-tumor immunities. But in these patients, if you just combine some like PD-L1 therapies or immune checkpoint therapies, it will improve a lot according to the microenvironment activations. This data was from the mouse data. The in-patients data, I think, is still going on. And people, just like you mentioned, whether we need to use the irradiation first or the like chemo drug first, is still need
the sequence. I agree. Very interesting question. Yeah, thank you.
I think this is a very fantastic question I met before. I mentioned like these two traditional treatments. Maybe I can try. I'll tell you answers in the mice experiment.
Hopefully, would be great. Would be great. Thank you.
Right. Thank you very much for the wonderful lecture as well as discussion. So we'll wind up this session for as of now. I will close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito. I would like to thank both speakers of today, Professor Richardo Oliverira and Professor Yang Hui, as well as the chairs, Professor Frederick Boob and Professor Tariq Juratli, for the time and support for the ACNS webinars. A very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, we have 450 people who have joined us live. Thanks to my co-host Dr. Liu Boon Singh and Dr. Ben for joining me today. So Until we all meet online tomorrow, it is bye bye from all of us. Thank you very much for joining.